Welcome all to the today's presentation. So today we will be discussing the NICE guideline published in February 2013, fertility problems, assessment and treatment. So today we are going to discuss the unexplained infertility and ART, which is a part of NICE guideline. We begin with our quote, master MRCOG with concept oriented clarity. So what exactly this NICE guideline? Yeah. Unexplained infertility, what does the NICE guideline mentions about the treatment? So NICE guideline clearly mentions that do not offer oral ovarian stimulation agents such as clomiphene citrate, anastrozole, letrozole, etc. They are not recommended in unexplained infertility. Okay. So unexplained infertility is a condition in which all investigations, male factor is normal, female factor is normal, and still there is no conception for more than 12 months. Okay. Then we label this case as a case of unexplained infertility. So in these cases, because the ovulation is also happening, tubes are patent, there is no role of ovulation inducing agent. This is what the NICE guideline mentions. And clomiphene citrate alone is ineffective. It does not increase the pregnancy or live birth rate. And especially when the patient is ovulating, it has got no role. Then what management is advisable? It is an expectant management, that is first. Okay. So advise regular unprotected intercourse for total duration of 2 years. Okay. This may include up to 1 year before fertility investigations. Okay. So how we diagnose unexplained infertility? Basically 1 year unprotected sexual intercourse followed by investigations. All investigations are normal. Then another 1 year is given for the unprotected sexual intercourse. That will make a total of 2 years. Okay. Then comes the IVF indication. Offer IVF if pregnancy has not occurred after 2 years of regular unprotected intercourse. So generally they ask you the scenario, either SBA or EMQ. They will give you the scenario which will mention all investigations of male factor, female factor, and they will give the duration of infertility which is more than 2 years, and they'll ask you the treatment which is recommended. Okay. So here it is an it becomes an indication of IVF, and there will not be unexplained infertility which is given as a diagnosis that we have to rule out considering all investigations are normal. They'll give you the mid luteal progesterone value, they'll give you the tubal patency test is done, etc., etc. Okay. So unexplained infertility, there is no oral ovulation induction, and after 2 years, try patient should try naturally. If there is no conception, then go for IVF. That is what is the NICE guideline says. So is there a role of IUI? Okay. So when IUI is to be considered, so when to consider unstimulated IUI? Okay. So as an alternative to vaginal sexual intercourse, this unstimulated IUI can be considered, but only in certain patients. Which are those patients? Those patients who have got a physical disability or psychosexual problems. Okay. So patients who are using partner or donor sperm. So if there is a physical disability or psychosexual problems, okay, then this IUI can be considered. People requiring special conception method, like patient where the patient male is a HIV positive. Okay. So these patients IUI is recommended, and same sex couple also the IUI is recommended. So there are very limited indications of IUI. Once we discuss about the once we think about IUI, just think about these conditions only. Is there any physical disability or psychosexual problem? Are we discussing about male partner and need for the post-sperm washing, and same-sex couples? So these are the limited indications for IUI. Okay. Then what is the duration of IVF? Okay. Now, what we discussed initially, the patient should try for 2 years, provided there is no indication of IUI. So if they are trying naturally, then we should try for 2 years. But if they are on IUI protocol for either of these indications, then what should be the duration before the IVF is thought? Okay. So if no conception after 6 cycles of donor or partner insemination, in spite of normal ovulation, tubal patency, normal semen analysis, offer further 6 cycles of unstimulated IUI and consider IVF only after 12 cycles. Okay. So here also unstimulated IUI is advised. So we have now a case where the patient is undergoing IVF cycle. Okay. So we will give 6 cycles of IUI, sorry, 6 cycles of IUI. If there is a failure, then we will give additional 6 cycles of unstimulated IUI. And if at the end of 12 cycles, if there is no conception, then we'll go for IVF. So natural conception, 2 years in unexplained infertility, and in IUI protocol, after 12 cycles of IUI, then you go for IVF. Is this concept clear, doctor?
Yes, sir.
So, IUI in common fertility conditions, is it indicated in unexplained infertility, mild endometriosis? No. So, what does the NICE recommends that in cases of unexplained infertility, don't use IUI. Okay. Mild endometriosis, mild male infertility, there is no role of IUI. Okay. So, this IUI which we have discussed is in relation to these conditions. Okay. In relation to these conditions, and there you will give 6 cycles, additional 6 cycles, and after 12 cycles, this is a case of unexplained infertility. So we'll go for IVF. Okay. Okay. So what does the role of IUI in? There is no role of in unexplained infertility, mild endometriosis, and mild male factor infertility. Okay. The only exception is strong social, cultural, or religious objection to IVF. Okay. So advise unprotected regular sexual intercourse total for 2 years before IVF, and may include 1 year before investigation. Okay. So these are prediction of IVF success. So most important is a female age, then previous failed cycles, previous pregnancy and live birth, and BMI. So female age, as age increases, there is a decline in the fertility. Then previous failed cycle, success reduces with increasing number of unsuccessful IVF cycles. Previous pregnancy and live birth is IVF will be more effective if she has conceived before. Okay. And BMI ideal will be 19 to 30. So outside this will be reduced success. Okay. Then there are lifestyle factors which are affecting the IVF. Alcohol intake more than 1 unit per day, maternal smoking, paternal smoking, and maternal coffee intake. Okay. So these are the factors which will reduce the IVF success. Okay. So what are the take home points? One, IUI is unstimulated and used only in specific conditions. That is what we have discussed. Then no routine IUI for unexplained infertility, mild endometriosis, or mild male factor. Then 2 years try naturally, then go for IVF. IVF success will decrease with age. As the age increases, there will be decreased success. High BMI, low BMI, smoking, alcohol, caffeine will have low success. Okay. Then previous pregnancy has got a better outcome. So these are the factors which are associated with the success of the IVF. Okay. Now concentrate on this slide. There is going to be either EMQ or SBA on this particular slide. Okay. So this slide talks about the IVF. Okay. And how many numbers of cycles of IVF. Okay. To be offered to the patient. Okay. So pre-IVF counseling is must, and we have to explain to the patient what exactly the one full IVF cycle includes. So one full cycle of IVF will include one episode of ovarian stimulation and transfer of all resulting fresh and frozen embryos from that stimulation. Okay, so one episode of ovarian stimulation and transfer of all resulting fresh or frozen embryos will make it as a one full IVF cycle. Okay. Now, how many cycles to offer? This is a either SBA or EMQ, and it is a age dependent. Okay. So if the age of the lady is less than 40 years, then how many cycles we are going to offer? It is 3 full cycles of IVF, which may or may not include ICSI. Okay. So that when we will offer 2 years of regular sexual unprotected intercourse, or after 12 cycles of IUI. Okay. Then we are going to offer 3 full cycles provided the age of the woman is 40 years. So they'll give you the scenario. Then you will have to diagnose that it is an unexplained infertility. Then she requires IVF, and very specific answer option will be depending upon age you need to select. What will be offered? 3 full cycles of IVF if her age is less than 40. Okay. Suppose she is 39, you have started her on IVF treatment, but she becomes 40, then you will complete only that current cycle. There will be no further cycle you are going to offer once she becomes the 40 during the treatment. Between 40 and 42, only one full cycle of IVF, which may or may not be associated with ICSI. Okay. But that should meet the following criteria: that she should not have any IVF treatment before, no evidence of low ovarian reserve, and she should also be counseled regarding the pregnancy at this above 40. Okay, so the risk of the IVF and the pregnancy at above 40 we should discuss. Then only single cycle of IVF we can offer after the age of 40. Okay, so this is what is they are asking, how many cycles you are going to offer depending upon age. So I hope this particular thing is very clear. And after the age of 40, do remember that we need to discuss that she should not have any previous IVF treatment. There should not be any evidence of low ovarian reserve, and she should be counseled regarding any high risk which are associated with the IVF treatment and because of the pregnancy at this age. Then only we will offer one full cycle of IVF after, if she fulfills these criteria. Okay. So this is the important thing on this cycle. Then what does the cancel means? Cancel cycles are generally due to the low ovarian reserve. Okay. So the cycle in which there is no egg collection, that is a cancelled cycle. Okay. And even if the cycle is cancelled, we have to take into account to decide whether she is suitable for further IVF or not. Okay. So one has to take a call on that if there is a low ovarian reserve. Okay. Then what are the key take-home points? The full IVF cycle is one stimulation and transfer of all fresh or the frozen embryos. Less than 40 years, we are going to offer 3 cycles. Between 40 and 42, we will offer only one cycle, provided she has not taken any previous treatment. Then she does not have low ovarian reserve and the counseling has been done. Okay, so that is what you should remember. Then direct IVF referral if no chance with the expectant management is also mentioned today. Okay. So procedures used during, what are the procedures which are used during the IVF treatment? One is a pre-treatment IVF. Generally, either progesterone or OC pills they are used, but as per the NICE, they are not recommended because they do not improve the live birth. Okay, so before starting stimulation, some kind of treatment, hormonal treatment, it is not advisable. It can be used only to schedule the IVF cycle. Okay, and in women not undergoing long down regulation protocol, that can be used. Okay, so the main role of pre-treatment IVF or this hormonal treatment is to schedule the IVF cycle. Okay, then prevention of premature LH surge. Okay, this premature LH surge we need to prevent, and that can be done by using, when you go for stimulation, use GnRH agonist down regulation protocol or GnRH antagonist. So when you are using agonist, go for down regulation protocol or use GnRH antagonist, then you can prevent the premature LH surge. Okay, so in which patients you should use GnRH? If those patients who have got a low risk of OHSS. Okay, so those patients who are at low risk of development of the OHSS, that means they have optimum number of ovarian follicles, there is no PCOS, and there are other few criteria also that along with OHSS we'll see. Okay, and protocol will be long down regulation protocol. Then third step is a control ovarian stimulation. So ovarian stimulation is mandatory in IVF. Okay, and we are going to use either urinary gonadotropins or recombinant gonadotropins. Then FSH starting dose will be based on the age of the patient, body mass index, and presence of polycystic ovaries and ovarian reserve. Maximum FSH dose is 450 international unit per day. Just remember this, may be asked in the SBA. Maximum FSH dose is 450 international unit per day. Okay. So monitoring during ovulation, ultrasound monitoring is must along with the estradiol levels. Okay. Purpose of monitoring, it assesses the efficacy and ensures safety. Okay. Then see this IVF, either clomiphene or gonadotropin stimulated IVF, it has got a higher pregnancy rate, and natural cycle IVF is not recommended. So in stimulation, always it is a stimulated cycle, no natural cycle IVF. Okay. Next is a triggering the ovulation. Okay. Uh, Now we have seen stimulation, then triggering the ovulation. Okay. So here what is recommended is SCG, either urinary or recombinant. Ultrasound monitoring is an integral part of cycle, and IVF unit must have a clear protocol for prevention, diagnosis, and management of OHSS. Next step is a oocyte and sperm retrieval. Okay, as far as oocyte retrieval consider, it is always a transvaginal oocyte retrieval. Offer conscious sedation. Follicle flushing is not recommended if there are more than 3 follicles which are present. It will not improve the oocyte yield or the pregnancy rate, but it will increase the pain and the procedure time. Okay, so TVS guided oocyte retrieval is indicated. For the sperms, surgical sperm retrieval is done before the ICSI. Technique depends on the pathology and the patient preference, and ICSI is plus minus. Okay, cryopreservation facilities must be available. So key take home message here is a pre-treatments, hormonal treatment is mainly for the scheduling of the cycle only. Okay, GnRH agonist we can use, but use long down regulation protocol. Antagonist can also be used, that is for the prevention of LH surge. Maximum FSH dose we have seen 450 international units per day. No natural cycle IVF, no growth hormone, no DHEA or assisted hatching, and conscious sedation for oocyte retrieval and OHS protocols are mandatory. Okay. Then next step is a embryo transfer. Okay. Here also there is a SBA, and most of the students get confused because they are age dependent. Last time we have seen the number of cycles of IVF to be offered. And here it is in during the process of IVF, how many embryos to be transferred. So this question is about transfer of the embryo. Previously, what we have seen, how many cycles are to be offered. Okay. So as far as embryo transfer is concerned, it is always a USG guided embryo transfer should be done. It improves the pregnancy rates. Embryo transfer not recommended if ET is less than 5 millimeter. Post-transfer bed rest only for 20 minutes. More bed rest does not improve IVF outcome. Okay. And embryo quality assessment, you have to assess at cleavage stage and the blastocyst stage. Okay, there are grading system like ACE and UK NEQAS. These are the grading system. They are used. Okay, so they are not asked just for the information. Okay, the number of embryos to be transferred. How many embryos will depend upon the age of the patient. Stop, Alexa. So less than 37 years, if the age of the woman is less than 37 years, so in the first cycle, it is always a single embryo transfer. In the second cycle, it is also a single embryo transfer if more than one top quality embryo is available. Otherwise, we'll go for double embryo transfer. And third cycle, it is maximum 2 embryos, that is DET, double embryo transfer. Okay. If her age is between 37 to 39, in first and second cycle, it is a single embryo transfer, provided top embryo quality is available. Otherwise, double embryo transfer. In third cycle, maximum 2 embryos. And between 40 and 42, in any cycle, it is always a double embryo transfer. Okay. So this is the question. And most of the time they will confuse you at 40 or 37 because 37 is included here. Okay. It is less than 37, but the 37, it is a first and second cycle single embryo transfer provided one or more top quality embryo is available. Otherwise, double embryo transfer. And third cycle is always a double embryo transfer. Okay. So this is what is the difference between the embryo transfer in the as per the age. Okay. So
So
I hope this.
in the group
Yeah.
less than 37 and 37 to 39,
Yeah.
the first cycle or second cycle
Yeah.
above it is separately written and
Yes, yes.
below it
It
is
is
was inserted in both
below
the
37.
same
It is
thing.
in the first cycle. It is always a second single embryo transfer. In second cycle, it may be single embryo or the double embryo,
If
depending
it is
upon
not of the top
top
quality, then
quality.
double.
You got it. And here it is
Yes,
the first and second cycle. They are going here. Okay. They
it
are
is
not
not.
giving trial the single embryo only if you have a top quality embryo. Okay.
So
Otherwise,
37 to 39 single embryo transfer only if it is top quality, otherwise double embryo.
otherwise double embryo transfer. Okay.
And in the less than 37, the
Here,
quality embryo doesn't
here they
matter.
have not mentioned about the quality. It is always a single embryo transfer they have mentioned. Okay, here it is a single embryo transfer. If you have a top quality embryo, the same is used here in the first and second cycle. Okay, so first cycle is a set, always set here below 37. Okay, so that is what is the difference here. Otherwise, third cycle is always a double embryo, and any cycle after 42 is a double embryo. Okay, so this difference they have given, I have just copied it from the guideline. Okay, because in the options we get confused. Okay, then special,
So,
I think, doctor, there is a little confusion here. Let us clear. Okay, here uh, we are discussing about embryo transfer. Okay, now
hmm,
this embryo transfer will depend upon the menstrual cycle.
hmm,
Okay, below 37 years we are going to transfer, whether it this is pertinent to whether you are going to do single embryo transfer or double embryo transfer. Those are the number of cycles offered. Okay, those what we discussed before, below 40 and above 40, they were the
yes,
number of cycles offered, not the menstrual cycles, I mean to say.
okay.
You
So
got
one,
it? Yeah. Then special situations. Okay, so embryo transfer strategy should be based on the donor's age. Okay, suppose we are using the donor egg. In that particular case, the age of the donor is to be taken into account. Okay, just now we have discussed about the embryo transfer strategy, single embryo or the double embryo, because recipient may be of a lesser age, but the donor may be of a higher age. In that particular case, we will consider the donor's age. Okay, so top quality blastocysts available, use single embryo transfer. Okay, the safety limits and counseling, maximum embryos per cycle, not more than 2. Okay, so key take home message: USG guided transfer is mandatory. ET less than 5 millimeter, avoid transfer. Single embryo transfer is preferred, especially with top quality blastocysts. Never more than 2 embryos. Then always counsel about multiple pregnancy and freeze surplus good quality embryos. Okay. When double embryo transfer is considered, counsel regarding the multiple pregnancy risk. Cryopreservation, always we will go for cryopreservation for the remaining embryos. Okay. Then frozen thawed embryo transfer in women with regular ovulatory cycle. Live births are similar with natural cycle or hormone supplemented cycle. Okay. So when we are considering the embryo transfer, the results are next cycle, transfer cycle we are considering. The results are same as a natural cycle as well as hormone supplemented cycle. Okay. Luteal phase support, only select progesterone. These are not recommended like SCG, etc., etc. Only progesterone is recommended for the luteal phase support. Okay. Then ICSI. Okay. There are very specific indications of ICSI. Again, this especially about ozoospermia, there will always be a question in the examination. Okay, so and most of the time ICSI is the expected answer. Okay, so severe semen abnormality, obstructive ozoospermia, non-obstructive ozoospermia, and failed or poor fertilization in previous IVF. So these are the only 4 indications for ICSI, and it is in male factor infertility. Okay, severe semen abnormality, obstructive ozoospermia, non-obstructive ozoospermia, failed or poor fertilization in previous IVF. Okay, ICSI will increase the only the fertilization rate, but not the pregnancy rate or the live birth rate. ICSI has got only effect on the fertilization rate. Okay. So genetic counseling, in which cases we need to do the genetic testing and genetic counseling when there is a severe ozoospermia or severe semen deficit or non-obstructive zoospermia, we have to do the karyotyping. Okay, and main undergoing karyotyping, you will always offer the genetic counseling. So this is also one of the SBA, which test is they may give you this semen report and what is the further investigation. So you need to establish the male karyotype. Okay. Then Y chromosome microdeletion testing is not recommended as a routine test before ICSI. Couples should be informed that a significant proportion of male infertility is related to Y chromosome gene abnormalities affecting spermatogenesis. Okay. So Then coming to
Okay.
the ICSI, we have discussed this. Okay, why chromosomal microdeletion testing is not recommended routinely. ICSI versus conventional IVF. Couple should be informed that ICSI improves fertilization rates compared with IVF alone. Once fertilization occurs, after that embryo development, pregnancy rates and live birth rates are similar. That is what we have discussed. ICSI will only have the increased fertilization rate, but embryo, pregnancy and live birth rates are same. Okay, so ICSI is mainly important in the male factor infertility. Always consider genetics before ICSI. Karyotypes required in severe semen deficit or non-obstructive azoospermia. Why microdeletion testing is not routine? ICSI will improve the fertilization rate, not the post-fertilization outcome. Okay. So
Okay.
then now here is a role of modalities in patients who are undergoing cancer treatment. Okay, up till now this has not been asked, but we'll just cover because sometimes they can take out questions from any part of the guideline. That is why I am covering. So people with cancer who wish to preserve the fertility. So especially those patients who will undergo chemotherapy or radiotherapy, these patients are suitable patients for cryopreservation. Okay, so what does the NICE guideline says? We need to take into account the impact of the cancer, impact of the planned treatment and future fertility options. Factors to consider before offering fertility preservation. What is the cancer diagnosis? What is the planned treatment, prognosis, expected outcome of future fertility treatment, viability of stored and post-thaw material. Okay. Then eligibility rules. Do not apply conventional infertility eligibility criteria for cancer-related fertility preservation. There is no lower age limit for cryopreservation in patients with cancer. And we need to inform patients eligibility criteria do not apply at storage stage. They do apply later when using stored material for NHS funded assisted conception. The donor insemination indications. Okay, this we have discussed. It is used only in obstructive azoospermia, non-obstructive azoospermia, severe semen abnormality, high genetic or infectious transmission risk, and severe RH isoimmunization. These are the only indications for donor insemination. Okay, one is a obstructive or a non-obstructive azoospermia, severe semen abnormality. If the ICSI is declined, okay, then high genetic or infectious transmission risk and severe RH isoimmunity. These are the indications for donor insemination. Then key principles are IUI is preferred over the intracervical. Then regular ovulation, you go for 6 unstimulated cycles minimum if she is ovulating. Okay. Then tubal assessment. If she is high risk, then before starting the IUI, you can do the tubal testing. But if she does not have other high risk factors such as history of PID or something like that, then you offer tubal testing after 3 cycles. Okay. Then oocyte donation. What are the indications? Premature ovarian failure, Turner syndrome, bilateral oophorectomy, post-chemo or radiotherapy, recurrent IVF failure, high genetic transmission risk. The mandatory counseling of the donor and recipient is must. Okay. And which are the factors, risk factors for the tubal risk factors? It is a previous PID, history of ectopic, previous pelvic or tubal surgery, and known endometriosis. Okay. So people with cancer who wish to preserve the fertility, what are the methods of fertility preservation? Permitted options are the sperm, oocytes, and embryos. For men and adolescent boys, offer sperm cryopreservation before gonadotoxic cancer treatment. Preferred technique is a freezing in the liquid nitrogen vapor. For sperms, it is always a freezing in the liquid nitrogen vapor. For women, we will offer the oocyte or embryo cryopreservation if they are medically fit for ovarian stimulation and egg collection. Procedure will not worsen their condition and sufficient time exists before the cancer treatment. So if she is medically fit, in that particular case, we will go ahead with the ovarian stimulation and egg collection. Okay. Then cryopreservation techniques, it is a vitrification method which is preferred for the oocytes, while for the semen, it is a freezing in the liquid nitrogen. Okay. Then storage duration, it is for 10 years we need to store. Sperm if can be extended beyond 10 years. Okay, if there is an ongoing infertility risk. Then they can ask you about the long-term safety of ovulation induction and ovarian stimulation. So is there any long-term association of this ovulation induction or the ovarian stimulation? So for females, there is absolute risk is very low. There is a small increase in the borderline ovarian tumors that cannot be excluded. So only borderline ovarian tumors, some association has been observed. In children, absolute long-term risk is very, very low for the ovulation induction and ovarian stimulation. Okay. So that finishes the topic. Okay. Uh, yeah, a few key take-home message. Cancer fertility preservation. It is separate from routine fertility rules. There is no age cutoff for cryopreservation. Main sperm cryopreservation is preferred for women. Oocyte or embryo cryopreservation if time and fitness allow. Vitrification is a preferred for oocytes and embryos. And ART drugs have minimum effective dose and long-term risk low but